So, other products that we store in blood bank include fresh frozen plasma and cryoprecipitate, as well as Octaplas. So, on our chart here, it gives our current stock levels of those products. So, we keep these in our plasma freezer, which is maintained to a temperature of lower than minus 25 degrees. And these products can be stored for up to 36 months or until they're thawed. So once FFP is thawed, this can be kept between 2 and 6 degrees for 24 hours, whereas cryoprecipitate can only be kept for 4 hours at room temperature. So FFP is used to replace clotting factors. So for example, for those who are bleeding, so in a major hemorrhage, we would give 4 units of FFP in each pack, whereas cryoprecipitate is used to replace low fibrinogen levels. So if during the major hemorrhage protocol we do test for fibrinogen, and if they find that the levels are lower than 1.5, then obviously cryo would then be issued. So we also hold Octaplas in our freezers as well, and this is a detergent treated FFP, which removes any bacteria or encapsulated viruses which might remain in the product. And those that product is obviously mainly issued to those patients with TTP to replace their clotting factors. And it's collected from a maximum of 1,520 donors. So it does give a more standardised dose of clotting factors. So the other products that we keep in our lab are prophylactic anti-D, which is 1,500 international units, and the 500 international units of anti-D. So I'll just lift these out of the fridge. So we keep these 2 different size doses because it's dependent on how many weeks pregnant the lady is to what dosage she would get. So routinely at 28 weeks gestation, an anti-D negative woman, we would issue the 1,500, which is this one here. So every pregnant lady of 28 weeks who's Rh negative will receive 1,500 of Roflac, and we'll issue the 500, so I'll issue this one here, for any woman over 12 weeks who has a sensitising event throughout her pregnancy. So, sorry, I should say that's any RhD negative woman over 12 weeks that has happened to have a sensitising event. So, after 20 weeks gestation, if a woman has a sensitising event, they will receive 500 international units and a Clyhauer to determine if the fetal bleed at this stage could be greater than 4 mil, because if it did, they would obviously require more than the 500 international units, which is just routinely given for a sensitising event. So when we perform our Clyhauers, we fix the slides in a reagent called fixative. We do this for 5 minutes and then we'll let them dry. We're then using a eluting reagent called working solution, and this elutes off the adult hemoglobin. So this is on for 20 seconds, and then we stain the slides with eosin counter stain. So this stains all the white cells purple. That's why they have a little purplish tinge when you look down the microscope. And they stain the fetal cells pink. So it makes it easier to differentiate between the adult and the fetal cells. So when each batch of these is performed, there's always one positive and one negative QC. And in cases where any fetal cells are seen or present, we would refer our sample to flow cytometry, who would do a quantification of the bleed. And like I said just before, if the bleed was greater than 4 mils, they would recommend a further dose of anti-D that needed to be issued to the pregnant lady. So once we have issued our red cells or our batch products or our frozen products, they then get stuck in this register. So this is our blood register, which is our tracking system for audit purposes, and obviously for traceability, most importantly. So each cross match that is performed and allocated to a patient, this little strip is printed out, as you can see, and it's placed in the register. So this printout has patient's details, so name and surname, hospital number, date of birth, the units that have been issued to this patient, which also include the expiry date. So this is then glued into the register and signed along with the date and time that the cross match was performed. And this is always signed by BMS, because obviously these are the ones that perform the cross matches. So this keeps an exact record of the date and time that the product has been placed into the issue fridge. And then our red cells are reserved for patients for up to 24 hours. And if they haven't been used within that 24 hours, they're then de-reserved and put back into stock. So by just holding them for 24 hours, obviously it allows us to ensure that the patient's sample is actually still valid for the cross match. So basically, patients who have received a transfusion in the last 3 months, or if they're pregnant, their samples are actually only valid for 72 hours, whereas those who haven't, their samples are valid for up to 1 week, so 7 days. Once the red cells are removed from the fridge, they're valid for up to 30 minutes before they can be placed back into the fridge. And if the red cells are kept out of the fridge for more than 30 minutes, then they have to be used within 4 hours. So they've got to be transfused to the patient within 4 hours of them being taken out of the fridge. If the transfusion isn't going to be complete within the 4 hours of the fridge removal time, it must not be transfused, and these units obviously must be wasted. So most red cells are removed by hand transport and using cool boxes. So it's really important that when a porter comes to collect the blood by hand, that is also signed out with a time and a date, so we know exactly what time it has left the lab. Then when they get to the satellite fridge on the ward, they will then sign the unit into the fridge. So they will stick a further tag like this into the register over there, and they will sign it, date it, and time, what time it is put into the satellite fridge. So then when a member of the ward staff come to collect the unit, they can then sign it out of what time it's been taken out and the date. So then we'll have a full traceability of when the blood was put into the fridge, when the porter removed it, and then obviously in the register, the satellite fridge, we have the time that it got into the fridge, so we know that it should have been put in within the 30 minutes. And then we know the time that it was taken out to be transfused to the patient. So yeah, I think that is everything on our traceability. So other services we provide from Blood Bank are, so we're involved in the activation of the major hemorrhage protocol. So we have a audit tool for the major hemorrhage protocol. So if the ward is to activate it, they ring switchboard, which then call us and let us know of the major hemorrhage. They'll give us details of which ward it's from, so that we can get in touch, obviously, with that ward, to get the full details of actually what is basically happening. So when the major hemorrhage is activated, we fill in this form here. So we get the person who's initiating it and the contact details, so we can get in touch with them if we need to speak to them urgently regarding anything. We get the name of the patient, the date of birth, so as much information as we can, and the time it's been declared, and obviously the BMS that is taking charge of the major hemorrhage. So in each pack we issue 4 red cells, 4 FFP and 1 bag of platelets, and obviously, like we spoke about cryo before, if the fibrinogen is less than 1.5, then cryo would also be issued. So as you can see in this box, we can document exactly what the clinician is requesting, because sometimes when they activate the major hemorrhage, they don't always want the full shock pack of what I've just explained you would get. Sometimes the maybes just want red cells to start with, and then they would call us later on if they wanted anything else. So we can document everything here, just so we know exactly what they're needing. So we'll also record the date and time of when the major hemorrhage has been stood down, and we'll have a little comment box here for anything that we might need to record. So stuff that maybe went wrong, or things that maybe needs to be explained and maybe is audited. So for example, if they activate the major hemorrhage protocol on the main telephone rather than directly through switchboard, or if they fail to stand down, we can record anything here that maybe needs looked into afterwards, once it's all complete.